Welcome to the PN2 Module 4 lecture, and we will get started with this. And remember, stop it as you need to as you're going through it, to rewind it, to capture some things that maybe you didn't hear clearly, or to pause and reflect on the information that's been shared with you. As always, students are responsible for all of the material that is in the resources that Rasmussen provides. And this slide includes the objectives for this module that you will also find in Blackboard. And we're going to be studying various concepts around perfusion. So it's important that you understand what perfusion actually refers to. And it is the flow of blood through the arteries and capillaries, delivering nutrients and oxygen to cells and removing cellular waste products. Here are some key terms that you also need to know. And so pause and take a minute and see if you can define the difference between these. Ischemia is an inadequate blood supply to an organ or part of the body, especially the heart muscles. Infarction is the obstruction of the blood supply to an organ or region or of tissue, typically by either a thrombus or an embolus, and this causes local death of the tissue. Anoxia, in comparison, is an absence or deficiency of oxygen reaching the tissues, or severe hypoxia. And claudication is decreased blood flow. There are two categories of perfusion. So when we talk about central perfusion, we're talking about that force of blood movement generated by cardiac output. And this requires adequate cardiac function, adequate blood pressure, and blood volume. And so you may at some point be asked to calculate cardiac output. That is stroke volume times the heart rate. And when we talk about the second category of perfusion, that's tissue or local perfusion. And factors that impact that type of perfusion is the volume of blood that flows to the target tissues. And this schematic should be reviewed for you. It's just a drawing of the cardiovascular system, starting with the heart, and you can see if you start on the right side of the heart, as the blood goes to the lungs, then back to the left side of the heart, and then out from there it goes to the upper body and eventually the brain, as well as going down to the abdominal aorta area, perfusing the kidneys, the liver, digestive tract, all of that going to the capillaries. And then once that oxygen has been taken or has gone out of the blood supply, and then the CO2 has gone into it, it returns back the way on the other side of the body, essentially returning to that right side of the heart to go into the lungs to be oxygenated again. So just be familiar with this. There's nothing really major on it, but if you don't understand this concept, it can make some later concepts a little more challenging. So let's take a look at impaired central perfusion. What is needed to maintain adequate perfusion? And the answer to that is adequate cardiac output. We mentioned earlier the equation for cardiac output is heart rate times stroke volume, but what does that really mean? And so your cardiac output is the amount of blood that's pumped out of the heart every minute. That's the cardiac output, and you have the formula to calculate it. But when we take a look at those factors, the heart rate, that's easy to determine. You just look at the pulse or listen to the apical pulse, and you have that component. But that stroke volume, the stroke volume depends on three factors: preload, afterload, and contractility. And as cardiac output decreases, there's going to be a decrease in tissue perfusion. The decreased tissue perfusion will lead to clinical manifestations, and you will see these manifestations of decreased cardiac output in all the body systems when there's that impaired central perfusion. Another key concept that you need to know when we're talking about perfusion is ejection fraction, or EF. And so EF refers to the percentage of the end diastolic left ventricular blood volume that is ejected out of the left ventricle during systole. And the normal ejection fraction is above 50 to 70%, and it's this is a value that's used to widely determine the function of that left ventricular contractility. Simplicity and familiarity are advantages of the EF as a measure of that left ventricular systolic function. So I have a few terms here that can be a little confusing, and so just bear with me. Try to write this down as you go to make some sense of it. So for a certain degree of contractility, and contractility is the intrinsic contractile strength of the myocardium or the amount of work that the heart can perform at a given load. And then the stroke volume of the ventricle is determined by the preload. So the preload is the end diastolic ventricular volume, pressure, or stretch, and is also impacted by the afterload, and that's the force of the opposing ejection. And the ideal indicator of myocardial contractility should not be affected by preload or afterload. Ejection fraction, which is an indicator of that contractility, is less dependent of loading conditions as compared to the stroke volume. However, the EF is afterload dependent and is depressed in situations with a high afterload. And so all that technical jargon, it's great to have it there, but how can we simplify that to make this easier to understand? So just when you think about preload, think about volume. And that preload is the volume of blood that's in the ventricles at the end of a contraction. So after the heart has attempted to empty everything out of the ventricles, how much is left in there? And so that's your preload. And then if you think of afterload as the pressure that the ventricles must exert in order to open the aortic and the pulmonic valve. And so things that impact that are vascular resistance and blood pressure and things like that. So hopefully that helps to clear it up a little bit. There's a bunch of YouTube videos out there if you want to take a look, and they explain it in a lot of different ways that will help you grasp this concept. What are the consequences of impaired tissue perfusion or local perfusion? And impairment of the tissue perfusion is associated with loss of vessel patency or permeability or inadequate central perfusion, and this results in impaired blood flow to those affected body tissues. So you have this localized effect, which in turn leads to ischemia and ultimately cell death if it's not corrected. And other causes of tissue perfusion can be organ specific. For instance, narrowing of local vessels, blood clots, and even dilation can affect perfusion of the local organs. What is heart failure? We talk about this a lot. There's been lots and lots of work that's been done over the last 10 years about how to support patients who have a diagnosis of heart failure to keep them out of the hospital. Readmissions are so common that the CMS has actually said, well, if you don't figure out how to keep your patients out of the hospital, if they come back in within 30 days, we're not going to pay for any of that. You're going to have to pay for it out of your hospital's funds. And that has become a huge motivator for hospitals to learn how to manage the care of patients with heart failure. And there's a lot of transitional care models that you will see where they're using nurse practitioners, play a big role in it. There's some great research that was done at the University of Pennsylvania of how utilizing nurse practitioners who have local, regular frequent contact points with those patients has impacted those patients' quality of life and the ability for them to manage their disease, to stay home. And we'll do an activity in class that will give you a chance to see how we can help that patient with heart failure. Heart failure is also called pump failure. Most recently, we heard it called congestive heart failure, but since then they have gone to just calling it heart failure. There are three major types of heart failure. We'll dive into each one of these individually. There's left-sided heart failure, right-sided heart failure, and high output failure. There are three main causes of heart failure. The first one is systemic hypertension. That is actually the most common cause of heart failures. And then we also know that patients who've had a cardiac infarction or an MI also have a very high risk of developing heart failure. And then there are structural heart changes as well. So valve dysfunction that can cause pressure or volume overload on the heart, which can contribute to a diagnosis of heart failure. When we're caring for a patient who has heart failure, there are a lot of diagnostics that might be used. They're going to keep a close eye on electrolytes because electrolytes can play a role. And then the B-type natriuretic peptide, or BNP, or we're seeing more often in the hospitals now, the NT-proBNP. In our reference for Rasmussen, we just put the BNP in there, but be aware that when you're in the hospital, they may be looking at that NT-proBNP and know the reference ranges for those patients that you're caring for. We're also keeping a close eye on the H&H because that can impact the patient. They may do a urinalysis looking for protein and high specific gravity, and then we do ABGs because patients who have heart failure often develop respiratory systems. Chest x-rays are a great tool to let us know if fluid's accumulating in the lungs. The echocardiogram is the best diagnostic tool. They'll often do a 2D echo, they'll call it, and they do it right at the bedside, and it's basically an ultrasound of the heart that's very specific, and we get some great measurements from that to know how the valves are functioning, and the results for ejection fraction come from the echocardiogram as well. We're going to look at ECG because anytime the mechanics of the heart isn't working, there's always the risk that some electrical conduction of the heart could be impaired, and they may put a pulmonary artery catheter in, and that is typically we're measuring fluid volumes for fluid overload and being able to find that balance between keeping that critical patient hydrated properly without overloading them. Left-sided heart failure was formerly known as congestive heart failure, and as mentioned, typical causes are hypertension, coronary artery disease, and valvular disease. Not all cases involve fluid accumulation, but that's often where we see exacerbations that present themselves respiratory-wise. And then there are two types of left-sided heart failure. There's systolic and diastolic. And so with systolic failure, when that happens, the heart doesn't pump out the blood the way that it should, compared to the diastolic left-sided heart failure. And in that case, the heart doesn't fill back up with the blood as it should. So either one of those could lead to this left-sided heart failure. This drawing might be helpful in your efforts to remember some of the signs and symptoms and clinical manifestations of left-sided heart failure. So we often see nocturnal dyspnea when our patient's feet get up, the blood returns to the heart faster, and then it gets overloaded into the lungs, and so they deal with difficulty breathing when they get their feet up. If we have a patient in the ICU, you may see an elevated pulmonary cap wedge pressure. That's, like I mentioned, that's a test that they only usually do in the ICUs. And then pulmonary congestion is a very common sign. We see cough, we hear crackles and wheezes. Sometimes patients are coughing up some blood-tinged sputum, and then the tachypnea as well. And all of those things also contribute to feelings of restlessness. There may be some confusion when the fluid is accumulating. Sodium can get diluted. Orthopnea can occur, tachycardia, exertional dyspnea, fatigue. We can see cyanosis, and weakness and oliguria are not on that list, but you can add them to your list of symptoms as well. Now let's take a look at right-sided heart failure. Some of those causes include left ventricular failure, so when the left side fails, fluid ends up accumulating and that resistance happens, and then the right side of the heart is not able to pump the blood into the lungs and then on into the left side of the heart, and so we end up with failure that's right-sided as a result of the left-sided heart failure. Patient might have had a right ventricular MI, and then pulmonary hypertension. We discussed right-sided heart failure in our last module as it related to COPD, and the COPD patients often develop this pulmonary hypertension. And so no matter what the cause is, when that right ventricle can't empty completely, then we get increased volume and increased pressure in the venous system and leads to peripheral edema as well. And we talked about cor pulmonale, and cor pulmonale is just another name for right-sided heart failure. They are one and the same. And that was a condition we learned about related to COPD. And this little picture might help you remember the symptoms of right-sided heart failure or cor pulmonale. These patients are usually very tired, so we see fatigue, we see peripheral venous, increased peripheral venous pressure, ascites, enlarged liver and spleen. Distended jugular veins are very common that we see those. This condition could be related or secondary to the chronic pulmonary problems. We've mentioned that several times. Anorexia or complaints of GI distress sometimes develop. We usually see weight gain. We also see dependent edema. Not listed on here are tachypnea, hepatomegaly, or a hepatojugular reflux could occur. So when we have the patients who have COPD with cor pulmonale, that's equivalent to the heart failure, the right-sided heart failure that we talk about, and we will be using the same guidelines to treat either of those. We'll talk about those in a later slide. We see high output heart failure less than we see right-sided or left-sided heart failure, and with high output failure, the cardiac output remains normal or maybe slightly above normal. And these conditions occur when the cardiac output is higher than normal due to increased peripheral demand. And there's a circulatory overload which may lead to pulmonary edema secondary to the elevated diastolic pressure in the left ventricle. And there are a variety of conditions that can significantly increase the body's need for blood and oxygen that result in this high output failure. These conditions include the septicemia and anemia and hyperthyroidism that you see here, but pregnancy can also lead to high output failure as well. How are we going to care for that patient who's in heart failure? One of the first goals that we're going to have is increasing that gas exchange. So we may have to provide some ventilation assistance. We're going to be monitoring that respiratory rate every hour to 4 hours, depending on how critical they are. It may be even more than that. We're going to auscultate breath sounds every 4 to 8 hours as well. Position that patient in high Fowler's if the patient is dyspneic, and this is kind of a general rule overall. If you have a patient who's laying down and they're short of breath, get them sitting up as high as they can. That sitting up position enables them to breathe deeper and to take in more oxygen, which can assist them. Don't leave that patient lying flat. And then we want to maintain that oxygen saturation at 90% or greater. We're going to be working on improving cardiac output and decreasing fatigue, so that could include managing their energy as well as cardiac rehab. There's great cardiac rehab programs out there that are focused on increasing their functional level and their activity plan. And so really our overall goal for these patients are to increase that activity or improve their activity so that we can improve the quality of life that they have. We're also going to be looking at preventing the pulmonary edema. So managing that fluid balance is a key goal, or many of our interventions are really focused on managing that fluid balance. So to improve cardiac output, we're going to be managing the preload, and some ways that we can do that is through nutritional therapy. So we want our patient to be on that low sodium diet, and then we're going to be looking at drug therapy, so diuretics as well as venous vasodilators. Your diuretics are pretty typical. Your Lasix, your Bumex are the most common ones. And then your venous vasodilators, they might be choosing nitroglycerin for that. So think about safety for these patients. They're on nitro and diuretics, so they can develop some hypotension. Keep a close eye on their potassium levels, and then look for dehydration because we can overcorrect a condition. And then for afterload, We're looking at ACE inhibitors, ARBs, ARNIs, or human BNP, which is the Natracor and Naseritide. I'm sorry, that didn't come out right. Your ACE inhibitors, so lisinopril. Lisinopril can increase potassium levels, so you want to keep a close eye on potassium levels with the patient who's on lisinopril. It's an antihypertensive, so it can cause hypotension. We know that a very common side effect of this is a persistent non-productive cough. So make sure patients know that that's what's going to be happening so they're not surprised and they don't think that they got sick from it. It's just one of the side effects of it. We're going to monitor these patients' blood pressures very closely. We're also looking for angioedema. Angioedema is a less common side effect, but it is a way more severe side effect. And when we see angioedema, there's swelling of the tongue, face, lips, and throat. And these are a medical emergency. So you want to let your patient know if you start them on lisinopril that this is a less common side effect that can happen or adverse event that can happen. But if they do experience it, they should call 911 right away. We also address the issue of contractility when we're talking about improving cardiac output. And some of the ways that we do that is through inotropic drugs such as digoxin. So when we prescribe digoxin, we're monitoring that heart rate, and we need to monitor digoxin levels as well. There's a very narrow therapeutic window with that, and the signs and symptoms of dig toxicity are not good for our patient. They may order some beta blockers. So with beta blockers, we're looking at monitoring heart rate. Patients often experience fatigue with this. Also monitor the blood pressure and make patients aware that some of these medications do lead to some sexual dysfunction, so they can talk to their provider about that. There are some beta blockers out there that have less of those sexual dysfunction side effects. And then aldosterone antagonist, and then HCN channel blockers. So hyperpolarization activated cyclic nucleotide gated. These are newly, that was a mouthful, wasn't it? Newly approved Corlanor, Corlanor is a brand name. It's a new one that's out. That's we're just starting to see this drug being used, these types of drugs. As I mentioned earlier, preventing or managing pulmonary edema will be a huge part of our focus with caring for patients who have heart failure. So we need to be vigilant for assessing for early signs. So if you start to hear crackles in the basis, we need to intervene right away, as well as assessing dyspnea at rest if they start to have disorientation or confusion. Make sure you're putting that patient in that high Fowler's position. We'll look at oxygen therapy if they need that. We'll often give the nitroglycerin to dilate the vessels to lower the work that the heart has to do to pump. We'll be giving IV rapid acting diuretics to help this patient. Sometimes they're on a Bumex drip for hours. And, if you have to do that for a patient, advocate for that patient and get a Foley catheter, because they will get absolutely no rest. They will be needing to get up and use the urinal or the commode or the toilet. And we know that they're already tired. We know they're often having difficulty breathing, and that can really tax them and delay their recovery. So this is one of the situations in which we will often put in a Foley catheter for 24 hours or 36 hours if we need to, until we can diurese this patient to a point where their heart failure is being managed, and then they can discontinue it and be able to have the energy to get up and use the bathroom. We may give IV morphine sulfate, so we're giving that to help with breathing. We know that one of the side effects of morphine sulfate is respiratory depression, and for those patients who are very dyspneic, giving them a little bit of this slows that breathing rate down just enough so that they can get adequate oxygen exchange with those breaths. And then we are continually assessing these patients who are at risk for pulmonary edema. I remember one of my first patients I took care of that had heart failure, and she actually was admitted. I admitted her to the floor, and she had pneumonia. That was her diagnosis from the ED. And so she was doing fine. I had 2 liters of oxygen on nasal cannula, and she was in bed. We probably had the bed at about a 45-degree angle, and she was doing great. And they wanted to take her down and do another x-ray. So radiology came and took her down, and she came back about 20 minutes later, and I went in to assess her when I got report from the radiology department. And this poor woman was struggling so hard to breathe, and it's going through my mind, what did you do with my patient down there? How did you break her? And I was a brand new nurse. I probably hadn't even been a nurse a year yet, and I was working with this amazing experienced nurse. And so I just went to her and I'm like, I think I need your support right now. This patient's really struggling and I'm not really sure what's going on. And so we went in together and she had me listen to her lungs, and she's like, what do you hear? And I'm like, nothing. And she said, exactly. She doesn't have any air movement going on. And so we ended up calling a rapid response. We pushed some IV diuretics and got her head raised. We had her head raised up at that point. And then we did transfer her to the ICU. And what had happened is she was dealing with some heart failure. They thought it was just pneumonia coming in, but really it was an exacerbation of the heart failure. And they laid her down flat for whatever test they were doing. I don't even remember at this point what it was, but whatever test in radiology, they laid her flat, and all of the fluid that had been accumulating down in her legs and her torso went right to her lungs and put her in flash pulmonary edema. And it was quite an ordeal, incredibly valuable learning experience for me, and one that you never forget when you have it. Teaching patients how to manage their heart failure at home is, as I mentioned earlier, it's a huge role that we play in keeping them having the best quality of life that they can while keeping them out of the hospital so that our hospitals can stay financially solvent. So our textbook used the acronym MAWDS, M-A-W-D-S, to help you remember how the teaching that we need to do related to the self-management. And so the M stands for medication. So when you're teaching your patient, teach them to take the medication as prescribed and do not run out. Running out is a bad thing. They can go downhill very quickly, especially when we're talking their diuretics, if they don't have it on a regular basis. And then know the purpose and side effects of each drug. And then avoid NSAIDs to prevent sodium and fluid retention. We know that NSAIDs can lead to fluid retention. A is for activity. So we want our patients to stay as active as possible, but we don't want them to overdo it. So they need to learn to know their limits. And they should be able to carry on a conversation while they're exercising. If they can't, they should probably slow down. And then weight. Our patients should weigh themselves every day at the same time in the same clothes. So I often tell patients, when you get up in the morning, most people go in, empty their bladder, and then as soon as you do that, get on the scale, weigh yourself. And have a little notebook, or even better, if you have a calendar, a planner, and after you've weighed yourself, write your weight on the calendar. And then take a look at what your weight was the day before to see if you've gone up a couple pounds, and then look at it from over the last week. Because if you've gained a pound within a day or two, or a couple pounds within a day or two, or 5 pounds in a week, you really should reach out to your provider to see about adjusting your diuretics for a few days so that we can get that weight back down to normal, and to be self-aware and to reflect on what have you been eating and drinking that could contribute to that. So that's the W is weight. D is for diet. So sodium intake should be limited to 2 to 3 grams as prescribed, and fluid intake may be limited to 2 liters. So they should have that conversation with their provider about whether they should limit that fluid intake. And then S is for symptoms. So they should know any new or worsening symptoms and notify the healthcare provider immediately. And sometimes it creeps up on them. They're doing just fine, and then all of a sudden they realize over 2 or 3 days that they're having a little bit more trouble walking to the mailbox to get their mail and to get back. And so making them aware that when you see these changes, get in touch with your healthcare provider right away so they can make some adjustments, help you manage this heart failure from home instead of having to come in and be hospitalized. This slide is a picture of a CHF stoplight tool, and most hospitals have some kind of a teaching tool that they use with their patients. It's important if this is being used at your hospital that you make sure you understand how to utilize the tool and be able to explain it to your patients. So we fill in what their goal weight is on this one in particular under that green zone. And then the signs and symptoms that are listed there, if that is what you're experiencing, then you are in the all clear. You're in that green zone, green for go. And then the column to the right tells them what steps they should take. Now, if you start to develop or experience any of the signs and symptoms that are listed below that in that yellow zone, they should call their provider right away if they're experiencing any of that. And so we want to make sure that if you have a tool like this, you fill in that information, the name and phone number, instructions for that provider. The red zone is a medical alert. So if they're experiencing any symptoms that are in that red zone, they should call their physician immediately if they start to go into it. And they might even have to consider, if they're really struggling, they should probably get to the, call the doctor, but they may send them to the ED, especially if there's confusion involved and dyspnea that's not being able to be controlled. So we just know that those patients who are in the red zone are really in danger. If we can catch them when they're in the yellow zone, we can quickly get them back to that green zone so that they can stay home. Back on slide 23, I would like to draw your attention to page 704 in your textbook, table 35.4. Just make a note of that and take a glance at it. There's some good information for you in that. I forgot to share that when we were on that slide. The next topic that we're going to talk about is infective endocarditis. If we were in a face-to-face classroom right now, I would ask you to pause this and take a few moments to answer the 3 questions that are here, just to prompt your individual thinking. So if you'd like to do that, pause it and then resume when you're ready to go forward. So I'm going to draw your attention to chart 35-8, and that is a list of the clinical manifestations that you can expect with infective endocarditis. So there's fever associated with chills, night sweats, malaise, and fatigue. A patient might also have anorexia and weight loss. Usually we see a cardiac murmur that can either be new or a change, development of heart failure, evidence of systemic embolization, petechiae, splinter hemorrhages, Osler's nodes on the palms of hands and soles of feet, Janeway's lesions. Those are flat reddened macula on hands and feet, and positive blood cultures. And how is it diagnosed? So we might first become aware of it just by doing a cardiac assessment and noticing that new regurgitant murmur. From there, they will probably do blood cultures and send those out to see if there is some kind of bacteria that's being circulated in the blood that may have found its way to the valves in the heart. And so another way that we diagnose this is through what's called a TEE, or transesophageal echocardiogram. If you ever get to see this, this is like one of the coolest tests ever. With this is an echocardiogram or an ultrasound, and you actually can see all the chambers of the heart and the blood flowing through it, and you can see the valves, and actually see the valves between the atria and the ventricles and the leaflets as they open and they close, and if there's vegetation on it of any kind from bacteria, you can see that. You can also see if there's any clots for like a patient who's had AFib. You can see if there's clots that have developed in the heart that are circulating around in that. What's really unique about this test is that, we spend a whole lot of time in nursing school making you get all of the bubbles out of your IV lines. And the first time you're asked to help with a TEE, they're going to tell you to take a couple cc's of air in a syringe, and you use a stopcock and 2 syringes, and you pass it back and forth and create this bubble, and then you actually send that air into the blood, which finds its way to the heart. And it's so contrary to everything that they've ever taught you to do. It's very unsettling the first time you have to do it, because you just feel like it's wrong and it's going to cause harm to your patient, but it doesn't. So how is infective endocarditis treated? And so Antimicrobials are the main reasons, they're going to be on antibiotics probably for at least a couple weeks. These patients are often very tired, so we're going to have them balance rest with activity. And they might have some supportive therapy for heart failure if this endocarditis has led to some heart failure, and possibly surgery if non-surgical interventions have been ineffective. Our next disease process that we're going to talk about is pericarditis, and the pericarditis is an inflammation or alteration of the pericardium, and the pericardium is that tissue, that sac that surrounds the heart. And so when it gets inflamed, our patients develop some symptoms that can be quite disturbing. So I'm going to draw your attention to Dressler syndrome, and this is actually a secondary form of pericarditis that occurs in the setting of an injury to the heart or the pericardium. And it consists, we usually see fever, pleuritic pain, the pericarditis or a pericardial effusion. And the Dressler syndrome is believed to be an immune system response after damage to heart tissue to the pericardium from events such as a heart attack, surgery, or a traumatic injury. What does our patient look like when they have pericarditis? They're going to complain of substernal precordial pain, so radiating to the left side of the neck, shoulder, or back. It's often grating, oppressive. It's aggravated by breathing, coughing, or swallowing. The pain worsens when in a supine position, but it's relieved when sitting up and leaning forward. We might also assess a pericardial friction rub. On our ECG, we may see some new ST elevation in all of the leads or PR segment depression, and we may see a newer worsening pericardial effusion as well. Acute cardiac tamponade is an emergency situation, and we're going to treat this with, we're going to increase that cardiac output by increasing the fluid volume. We're going to do hemodynamic monitoring. This patient's going to be in an ICU. We're going to see increased right atrial, pulmonary artery, and wedge pressures. They may treat this with a pericardiocentesis. They may put in a pericardial window or pericardioectomy as part of that treatment. For information on how to care for the patient with pericarditis, I'm not going to read it to you. You can read totally on your own, but I do recommend that you pause and go to chart 35-9, and you'll have a nice list of that. Pain management's going to involve NSAIDs. There'll be some antimicrobial therapy if it's determined that it's bacterial in nature. And then we're going to be monitoring for pericardial effusions and the cardiac tamponade, which, as we mentioned earlier, is an emergency. Next, we move on to cardiomyopathy. And what is cardiomyopathy? So it is the subacute or chronic disease of cardiac muscle. There are 4 types of cardiomyopathy. The first one is dilated cardiomyopathy. This is actually the most common, and in this type of cardiomyopathy, the heart becomes enlarged and is unable to pump efficiently. Hypertrophic cardiomyopathy, the heart muscles become thick and they become unable to pump. Restrictive cardiomyopathy has restrictive filling of the ventricles, and known causes include buildup of scar tissue. Sometimes this is just idiopathic, or the buildup of abnormal proteins. So amyloidosis is an example of that, and so the buildup of those proteins in the heart muscle. Arrhythmogenic right ventricular cardiomyopathy. This condition causes part of the myocardium to break down over time. And this increases the risk of an abnormal heartbeat, hence the term arrhythmia, or arrhythmogenic, and even sudden death. And this is actually hereditary in nature. When caring for a patient who has cardiomyopathy, we will be using drug therapy, diuretics will be ordered, there will be vasodilating agents, and the cardiac glycosides such as digoxin will be ordered. We want these individuals to avoid the toxin exposures that may have contributed to this. They should be instructed to avoid alcohol, and they may require some surgical management. Sometimes they have to have an implanted cardiac defibrillator. They might need a ventricular myomectomy, and percutaneous alcohol septal ablation, and even a heart transplant. I took care of a patient who traveled to China, I believe, and had come back, and about 2 or 3 weeks after he came back from China, he developed these symptoms. He was just extremely tired, and he came in, and we determined that he had developed cardiomyopathy within weeks, like 2 or 3 weeks, and it was determined it came from a virus that he contracted while he was in China, and it was just devastating for him. He was a business owner and was like the only worker in his business that he owned, and it was just devastating for him and his family that he had to figure out how to slow down and still provide for his family while he was taking care of this. And we knew that he would never return to the level of functioning that he had had a month prior to that. Blood pressure goals are age-related, so for those who are over age 60, we want their blood pressure to be below a 150/90, and then for those who are under age 60, we want it below a 140/90. And according to the Joint National Committee 8, JNC 8 guidelines, patients whose blood pressures are above these goals should be treated with drug therapy. Essential hypertension results in damage to vital organs and causes medial hyperplasia or thickening of the arterioles. Common risk factors are obesity, smoking, stress, family history, and African American ethnicity as well. Take a look at Table 36.1 for some important information. Common causes of secondary hypertension are renal disease, primary aldosteronism, pheochromocytoma, which is a really long, complicated, tongue-twisting word that is a tumor on the adrenal gland. Cushing's syndrome can lead to it, pregnancy, and then medications such as estrogen, glucocorticoids, mineralocorticoids, and sympathomimetics. So sympathomimetics include things like ephedrine, amphetamines, and cocaine. All of these can contribute to secondary hypertension. This section should pretty much all be a review for you at this point, but we do want to go over it again. So clinical manifestations, sometimes there's no symptoms at all. Somebody can have moderately elevated blood pressures over time that is causing damage to vessels throughout the body with no symptoms. But sometimes patients have headaches, they'll have blurred vision, facial flushing, dizziness or vertigo, and fainting can occur as well. So what are we going to do about it? Diet, so teaching patients how to restrict sodium. That's very, very difficult. It's hard to go out to eat. It's hard to eat any convenience foods out there. They're just loaded with sodium. So having a consult with a dietitian could be very important. Weight reduction, even a 10% weight reduction can significantly impact blood pressure. Reduce alcohol intake. Exercise can have a powerful effect on it. Decreasing stress levels, that too. Some people, just the stress that's happening in their life is enough to have elevated blood pressure, and when they modify that part of their life, they can bring it down without making that many other additional changes. Avoiding smoking or tobacco use, so it's the effect the nicotines have on the arteries that cause that elevated blood pressure. And then there are complementary and alternative therapies as well, if you think about meditation, and there are many others. So for drug therapy, if you'd like to go to chart 36.1, there'll be some good information for you there, but we'll go over this list. So when we're talking about diuretics, make sure you're watching for hypovolemia. If you have a potassium-sparing diuretic, patients need to be instructed to avoid foods that are high in potassium. If they're taking loop and thiazides, they need to eat foods that are high in potassium because they cause potassium and magnesium excretion, and glucose control can be affected, as well as uric acid retention, so they're at risk for gout. So renin inhibitors, aliskiren, and that's a brand name Tecturna, they might be prescribed. Your beta blockers, we're watching for heart rate and blood pressure. We have to use caution with diabetes. This can cause fatigue and depression and sexual dysfunction. We mentioned that previously. Your calcium channel blockers. You may see a decrease in the heart rate. Vasodilation can occur. They need to avoid grapefruits and grapefruit juices. These enhance the effect of these drugs. Your ACE inhibitors, we're monitoring potassium level. They can reduce the excretion of the potassium, which can lead to some high levels, and then acetylcholine esterase. So your ARBs, we're avoiding foods high in potassium. We're using caution with patients whose systolic blood pressure is less than 100. Examples of these are your Cozar, which is losartan, olmesartan, which is Benicar, telmisartan, which is Marcitis, and valsartan, which is Diovan. Your aldosterone receptor antagonist, spironolactone, is a non-specific aldosterone antagonist, and the eplerenone is selective to the aldosterone receptor. So just a little bit tidbits of information for you there. Let's take a look at a scenario. We have a patient who's in the PACU who just had an appendectomy, who suddenly develops tachycardia with muscle rigidity and a rising temperature. What might the PACU nurse suspect is happening? So you should have already done some work on your reading, so you may have an idea of what this is. If you guessed malignant hyperthermia, you are correct. Malignant hyperthermia is a medical emergency, and there is a very strong genetic predisposition to this. So if you have a family member who's even like two steps away from you who had this, you have a possibility that you could develop this. This condition is often triggered by general anesthesia. Early clinical signs of it include an increase in CO2. So this is one of the first things that you're going to see, even with increasing minute ventilation. So, we're keeping a close eye on these patients and not looking at just pulse oximetry. That's a late determiner of it, but that increase in CO2. Tachycardia is going to develop. They'll develop muscle rigidity, tachypnea, and hyperkalemia. Later signs include fever, myoglobinuria, and multiple organ failure. And these individuals, they get the general anesthesia and then their body responds. And this is truly a life-threatening condition that develops. There will, all of the ORs and some of the other areas where they do care for patients who have common general anesthesia will do what's called malignant hyperthermia drills. And so if you suspect your patient has this, you're going to activate that malignant hyperthermia response team. And they're going to discontinue and eliminate any of the potent inhalation anesthetics that may have triggered this. They're going to increase the ventilation rate with 100% oxygen. They'll add an inline charcoal filter, activated charcoal filters with it. And then they're going to start treatment with intravenous dantrolene. And it's quite an undertaking to mix this dantrolene and to get it ready. While that's being mixed, another part of your team is going to begin actively cooling by all available routes. So we're going to give cold IV fluids. We're going to pack the axillary and the groin and the body with possible ice packs, just tuck them in the armpits. They may put the patient on a cooling blanket right away. And then we're going to be monitoring and treating for any electrolyte and pH abnormalities. There is a family in the Wisconsin state line area that has lost a loved one to malignant hyperthermia. It happened many, many years ago, but their name is mentioned in all the trainings that happen in this area with trainings related to the malignant hyperthermia. The last name is Schiffelbein, but when people marry into other families, names change, so you may have a patient. So always ask that. It's part of the screening for preoperatively. And most people who know they have that family history they know to advocate for themselves and their loved ones related to this condition. We're going to move on to a new topic. And these two conditions sound very similar. They look very similar, but there is a difference between them. Arteriosclerosis is the thickening or hardening of the arterial wall, and it's often associated with aging. Now, atherosclerosis is a type of arteriosclerosis, and it involves formation of plaque within the arterial walls. Treatment of atherosclerosis begins with knowing your labs. Do you know what your cholesterol level is? Do you know what your LDL is and your HDL and your homocysteine levels? Nutrition therapy, making adjustments to your diet to help with that. So much of this, though, is honestly genetic. They're finding that the genetics plays an even bigger role than they originally thought. And so a lot of times they will recommend drug therapy. If you use tobacco products, they will recommend that you discontinue the use of tobacco products, and exercise will play a big role as well in treating the atherosclerosis. This slide lists common medications that are used for the treatment of atherosclerosis. Know that your statins lower your LDL, cholesterol, and your triglyceride levels. The acetamiprid blocks absorption of the cholesterol. Know your patient teaching for the drug therapies. The alirocumab, this is quite a mouthful, and the evolocumab. These are newly approved drugs for patients who have this strong family hypercholesterolemia and those who've been unable to lower their LDL with the existing therapies. This is actually a sub-Q injection that's monthly or bi-monthly. And like I said, they're newer. And then niacin is often prescribed. It's given in low doses. Know that this can often cause hot flashes for your patients. Our next topic is peripheral artery disease, and this is an alteration in the natural flow of blood through the arteries and veins of our peripheral circulation, and often a result of the systemic atherosclerosis. See chart 36.3. There are stages. You don't have to memorize each of these. Just look over them and just have a little bit of familiarity with it. Clinical manifestations include intermittent claudication. The pain occurs even while at rest. There's numbness and burning. If there's inflow disease, they'll have discomfort in their low back, their buttocks, or their thighs. If it's outflow disease, they experience burning or cramping in the calves, ankles, feet, and toes. There's often hair loss and dry, scaly, paler mottled skin. Toenails tend to be thickened. And in severe arterial disease, extremities can be cold or gray, blue, or darkened. Pallor can occur with when the extremity is elevated, but when it's dependent, it'll be rubor or this red ruddy. And sometimes we even see muscle atrophy with this. Management of this that is non-surgical includes exercise and positioning. We're going to promote vasodilation, so we want to keep usually the extremities warm. Drug therapies, including antiplatelet agents, and they may do percutaneous transluminal angioplasty. So they basically go in through the femoral artery and go in and kind of root it out. Or an atherectomy, which is if there's a clot or an occlusion of some kind, they'll go in and pull that out and remove that. This might be a great slide to print out as a study guide. I'm not going to read it to you, but it shows a comparison between arterial diseases and venous disease. I'd also like to refer you to chart 36.4 and 36.6. This is information. Chart 36.4 shows you the difference between some pictures and a comparison between arterial, venous, and diabetic ulcers. And then chart 36.6 has some patient and family teaching that is important. And because we love alliteration, we have 6 P's of arterial insufficiency: pain, pallor, pulselessness, paresthesia, and paralysis. Also the poikiloothermia, which is a fancy word to say coolness, but we needed that 6 P so that it all started with the same letter. So you will probably see these again. The story and the picture that I am sharing here, I am sharing with permission from the family. Prior, I talked to them about the situation, and they agreed that it would make this beautiful woman happy to know that maybe her story helped somebody to learn about a certain disease process. So this is a story of a 30-year-old wife and mother of 3 small children, and she was the image of health and vitality until April 12th of 2014. She'd been experiencing some mild nausea a few days earlier and had felt a little tired, but she was the mother of 3 young children. That was not surprising to her or her family. She had a history of high cholesterol, which she was treating with diet and weight loss at that point. And she was on her way to work, and she dropped her children off at daycare on her way. And she felt a little funny, so she decided to stop at the ED on her way to work. Her vague symptoms changed to a medical emergency in the emergency department. She was rushed to the cath lab, and despite the valiant efforts of an exceptional cardiac team, 3 little children lost their mother that day. She had experienced a ruptured aortic aneurysm that led to a cardiac arrest. And I show this because we don't always know who has conditions that are abnormal. We don't get to see them until they start to present symptoms. And so just encouraging you that when your patients, especially women, when we have these weird, vague symptoms, we need to pay attention to them because our bodies often tell us something's not right, but we may not know specifically what it is. And for this beautiful woman, that action came too late for her. So take just a couple minutes and answer these for yourself. We're talking about aneurysms now. What are they? Where can they occur? And what causes them? So go ahead and pause. Okay, so aneurysms are a permanent localized dilation of an artery, which enlarges the artery to at least 2 times its normal diameter. And they can occur in any artery, but most commonly we see them in the aorta. They can also occur in the brain though, and abdominal aortic aneurysms are the most common. So what causes them? Atherosclerosis is the most common cause. Also hypertension, hyperlipidemia, and cigarette smoking, and age, gender, and family history also play a factor. So we're going to talk about aneurysms and those that are central, so in the core of the body. So we'll start with a AAA, abdominal aortic aneurysm, and pain related to this is usually steady with a gnawing quality, unaffected by movement. It can last for hours or days. Patients often have pain in the abdomen, flank, or back. Sometimes you can see an abdominal mass that's pulsing. And then rupture is the most common complication, and it is life-threatening, as we discussed in the case of the woman in the previous slide. So thoracic aortic aneurysms, these individuals have back pain. So, and it's manifestations of compression of the aneurysm on the adjacent structures. So they might also develop shortness of breath, hoarseness, difficulty swallowing, and the mass may be visible above the substernal notch. So sudden excruciating back or chest pain is symptomatic of that thoracic rupture. When you begin working, or if you are working in a hospital right now, you will be aware that there's a lot of focus put on preventing venous thromboembolisms, or VTEs. So this can include DVTs as well as PEs. A thrombus is actually a blood clot. The thrombophlebitis is inflammation of the vessel resulting from the thrombus. PE is a pulmonary embolism, so that's essentially a clot in the lungs. And then Virchow's triad is 3 things that when we understand them, so they are the hypercoagulability, venous stasis, and injury to the vessel wall. And they provide a model for understanding many of the risk factors that lead to the development of a VTE. So when we have those 3 things happening, we know that patients have that increased risk for a VTE. So those 3 were injury to the vessel wall, venous stasis, and the hypercoagulability. Phlebitis is inflammation of the vessels. And then, like I mentioned, core measures, we have to take we have specific actions we have to take to prevent the development of VTEs in our patients, because we know that patients who are in the hospital are at increased risk. And so some of those include I'm getting ahead of myself, so I'm going to stop with this slide right here, and we'll move on and we'll cover what we're going to do to prevent them a little later. It's really important to understand that preventing a VTE is so incredibly important and so much easier to prevent than it is to treat one once it develops. Signs and symptoms of a DVT, which is a type of VTE, are calf or groin tenderness or pain, sudden onset of unilateral swelling of the leg, so on one side, one leg is more swollen than the other. We used to always check for Homan signs, but this is not advised anymore. There's risk that that clot that developed in the calf might actually be mobilized by the test that we do for the Homan sign. There's often localized edema. Venous flow studies will probably be performed, and a venous duplex ultrasound, or they call it a venous duplex scan, might be performed. They also might do an MRI. And honestly, the D-dimer is one of the first things that they will do. So a D-dimer doesn't prove that there's a clot somewhere. The D-dimer, if there is an elevated D-dimer, it's suggestive that there might be one, but there are other reasons that a D-dimer could be positive besides a clot. So it's that first step. It's a blood test. It's super easy to run. And so if that's positive, then they may do some additional studies to see. If it's negative, then unless there's other evidence that is strongly suggesting that they have one, it could be ruled out. A patient who has a PE or pulmonary embolism is going to present with shortness of breath and a cough, hemoptysis, so meaning they might be coughing up some bloody sputum. They may be experiencing back pain, acute respiratory distress. A CT scan will be performed, so it's important that we get an 18 gauge in the anacube. That's what's preferred to be able to do that test. And then they'll also do a D-dimer to see if that is elevated. For non-surgical management, your patient will most likely be put on bed rest. Well, we don't want them to be, they may have bathroom privileges, but we don't want them out walking in the hall, especially if it's a DVT in the leg. If you mobilize that clot, they could have a stroke or an MI from that. Or it could travel to the lungs and develop a PE as well. So we do put them on bed rest. And then we begin additional preventative measures. We're going to start them on the unfractionated or low molecular weight heparin, and they'll also start them on warfarin. They'll do what's called a bridge therapy. And I think I will not go into that because I think that's our discussion question this week. They may also choose to do thrombolytics if the patient is a candidate for that. If they think, so our heparin and our warfarin don't break up the clots that are there. They just prevent additional clots from developing, but they may choose to do a thrombolytic. So TPA is one of the most common ones in order to break that apart, or alteplase is another thrombolytic. So it's important when we have patients who are on heparin and on warfarin to know that know what the normal ranges for those. So when we're doing heparin, we're checking the APTT. Normal heparin, or excuse me, normal APTT range is 25 to 35 seconds. So normal INR is less than 1.1. And so if a patient is not on any blood thinners, we would expect their levels to be less than 1.1 if they're for the INR. If it's elevated and they're not on blood thinners, that's a reason to pause to look why. But in this case, we're talking about intentionally giving patients heparin or warfarin as a blood thinner. And so we're trying to get that patient to a therapeutic range or therapeutic level with those two medications. And when we're giving heparin, we're going to be checking the APTT regularly, and we want to see a range that is 1.5 to 2.5 times the normal range. So I'm going to let you do the math because it'll help you remember it better, but the normal for the APTT is 25 to 35. So calculate for yourself what that therapeutic range is. And likewise, your INR should be less than 1.1. So therapeutic range for INR is actually 2.0 to 3.0. So when we're giving these medications, it's important that we're monitoring for signs and symptoms of bleeding. Make sure you educate your patient accordingly with that. So the NOACs, this was changed recently to, let's see here, Xarelto it was changed recently to DOAC. So I don't know why they changed what it was called, but the two most common ones that we have seen lately are the Xarelto and the Eliquis. Those medications don't require you to have the regular levels checked for therapeutic level. However, there isn't an antidote for them. So if there's an emergency and you have to take them to surgery, there is not a way to reduce those. So that's that slide. Surgical management can include a thrombectomy where they go in and surgically remove the thrombus. They may do a ligation or use external clips. And then we often see an IVC filter, which stands for an inferior vena cava filter. And they will go in through the groin and place this IVC filter in the inferior vena cava. And its purpose is that if there are any clots that are developing, that it would capture it and contain it in that filter before that clot could go to the heart or to the brain to cause any clots. So those are surgical management if needed. Nursing considerations and patient teaching include safety. So we're always assessing for increased bruising, making sure that our therapeutic levels are in that range, and that then the anticoagulant therapy involves that. So take a look at chart 36.7. This is for patient safety and quality of care of anticoagulation therapy. Some good information there. And then there's food and drug interactions with warfarin. You can find that on chart 36.8, and I would recommend that you just take a peek at both of those charts. And this is the end of this module's recorded lecture. We'll have some time in class for you to ask questions. Please be thinking about them and come prepared so that I can clarify any concerns or any things that you didn't have a good understanding of. And we'll have, again, some activities to help reinforce. Hope you have a great week.